I'd like to thank the organizing committee for inviting me to give this presentation on EBUS for mediastinal staging of lung cancer. I have no conflict to disclose. The presentation is going to go as follows. First, we'll review mediastinal staging of lung cancer. Then we'll talk about the EBUS equipment, and then we'll review the published data on the use of EBUS for this application. As Dr. Mizian mentioned, lung cancer is the leading cause of cancer death worldwide. It's responsible for 1.2 million deaths in 2008 and in 160,000 deaths in the US in 2009. To give you perspective, it's responsible for more deaths than prostate, breast, and colorectal cancer combined, the second, third, and fourth leading causes of cancer death. Staging is the most important step in management of lung cancer. It not only determines prognosis, but also determines therapy. In the absence of distant metastasis, I cannot overemphasize the importance of staging the mediastinum, because mediastinal lymph node status is the most important determinant of therapy in these patients. Also, the 5-year survival varies significantly depending on the lymph node stage. On presentation, anywhere between 5 to 55%, whether the lymph node stage is N1 to N3. To classify mediastinal lymph node, we follow the mountain Dresler classification that divides lymph nodes into stations. As seen on this figure, paratracheal lymph nodes are stations 2 and 4, and there's right and left. Subcarinal is station 7. Paraesophageal is 8, pulmonary ligament is 9. The subaortic and periaortic are 5 and 6. And these are these are N2 lesions when they're ipsilateral to the primary tumor, and N3 when they're contralateral. And the so-called N1 lymph nodes are 10R, the hilar, 11R, the peribronchial, and the peribronchial intrapulmonary are the 12, 13, and 14. And these are N1 lymph node when they're ipsilateral to the lesion, and N3 when they're contralateral. So again, to reiterate, according to the 7th TNM Classification of cancer, N0 is when there's no regional lymph node. N1 stage is when we have ipsilateral hilar, so 10R if the lesion is on the right, and ipsilateral peribronchial, ipsilateral intrapulmonary also N1. The N2 lymph node are the so-called double-digit, single-digit stations. These are the ipsilateral mediastinal and subcarinal. And when any of these lymph nodes is contralateral to the lesion, we have N3 station. This figure is to show you how lymph node station affects the overall stage and the therapy. We have lymph node stage here, we have the T stage here, and we see that in pretty much any lesion, if we have an N3 lymph node, that determines stage 3B and basically precludes surgery just by making that diagnosis. And for most of the lesions, if we have an N2 lymph nodes, we have a stage 3A, except for T4, it's 3B, and that implies a multimodality treatment that precludes surgery in most patients, and but still allow surgery in a subset, maybe patients who have a small lesion that can be removed with lobectomy and have a non-bulky N2 disease. Smaller stages can still benefit from surgery. That's not working all the time. It's variable. Maybe I'll lose this here. Oh, no. So how do we stage the mediastinum? Most patients present with a CT. So CT is usually the initial staging test. On CT, lymph nodes more than 1 centimeter are considered abnormal. However, we know that smaller lymph node can harbor metastasis in up to 15 to 20% of the cases. That's very well known. And even enlarged lymph node may be benign. That's reflected in the pooled sensitivities and specificity of CT reported here, about 51% sensitivity and specificity of 85%. Now, the advent of PET gave us a lot of hope as it can detect activity in small lymph node. And that's reflected in an improved sensitivity to 74%, but this is still quite low and misses quite a bit of false negatives. So CT and PET are limited by false negative and false positive results, and tissue confirmation is needed with positive and most negative results. However, they're still very helpful in guiding decision on how to best obtain tissue for diagnosis and staging. How about invasive stages? What do the guidelines tell us about that? In the absence of metastasis, the guidelines tell us that invasive confirmation of the radiographic stage is recommended for discrete mediastinal lymph node enlargement, regardless of the PET scan. So if you have a lymph node, regardless if the PET scan was positive or negative, you have to validate this lymph node is positive or negative by invasive means. Even in a radiographically normal mediastinum, so even with sub-centimeter lymph nodes, in the presence of central tumor or N1 node, invasive staging is mandated, regardless of the PET finding. On the other hand, if you have a PET positive mediastinum and a peripheral clinical stage 1 tumor, you also need to make sure that this is not a false positive, as it can be a result of inflammation or other diseases, or sarcoidosis, as an example. So when is invasive staging not needed? It's in very limited cases, such as the presence of a peripheral clinical stage 1 lesion, if the finding of the PET scan on the mediastinum are negative. So that's basically the only situation where the PET scan will help you rule out disease in the mediastinum in the presence of a stage 1 looking lesion. And of course, in the case of an extensive mediastinal infiltration, there's no need to making sure that this is actually tumor. So up until recently, the only reliable method of staging was surgical. We had cervical mediastinoscopy, which allows sampling of the paratracheal, station 1 to 4, and the anterior subcarinal. So not always helpful for the subcarinal if it's the posteriorly located. For the station 5 and 6, the prevascular periaortic, the anterior mediastinostomy helped us diagnose that, the so-called Chamberlain procedure. For the other lymph node, the paraesophageal and the posterior subcarinal and the pulmonary ligament, they were unable to be assessed by mediastinoscopy and needed thoracotomy. Now, blind TBNA, the Wang procedure, is a non-invasive alternative. However, we all know that it's plagued by low sensitivity, reported here at 39%, and variable sensitivities depending on the operator, reported 17 to 61, because it's essentially a blind procedure. And anytime we venture away from the subcarina, we have the risk of arterial puncture. So it remained poorly utilized. Now, the advent of EUS FNA showed us the advantage of real-time ultrasound guidance in improving the sensitivity of minimally invasive procedure in sampling the mediastinal lymph node. It showed good sensitivity in the range of 70 to 92% for station 7, 8, 9, and 4L. These are the stations accessible to EUS. They're surrounding the esophagus. However, it does not allow a consistent sampling of station 2 and 4R, the paratracheal, or the hilar and peribronchial. And of course, it doesn't allow airway inspection. Now, since all the mediastinal structure surrounds the airway, it was logical to try to develop an airway-based similar technology. And that's where we get to the development of EBUS TBNA over the last decade. So I'll talk a little bit about the equipment here to make sure everybody's familiar. We have two kinds of EBUS. There's the radial probe, which allows us, on the right-hand side here, which allows us to examine the airway and distal lesion. And we have the linear convex probe, which is the subject of our talk down here, and allows the staging and sampling of the mediastinal lymph node. The equipment is similar to a regular bronchoscope, except that it has an ultrasound transducer on its tip, and it's hooked to an ultrasound scanner, which allows us to make adjustment to the image and trigger the Doppler functionality, which is very helpful in visualizing the vessels. This is just the more advanced processor that we're currently using. The diameter of the bronchoscope is 6.9 millimeters, so it's larger than a regular bronchoscope. Cannot insert it in the nose. Usually you need to go through the mouth. The ultrasound has a scanning degree of 50 degrees. the vision, the optics are skewed, and they're at 35 degrees angle. So you cannot see below the diaphragm, below the bronchoscope without flexing it. You have to flex it to see below. Otherwise, you see it in front of you. The working channel has 2 millimeter diameter, and it's also at an oblique angle. So it's very important to make sure the sheet is outside of the working channel before the needle is deployed. Otherwise, it will break the channel and the ultrasound. Very costly to repair. This is just some images to show you what we're talking about with the oblique view. This is how we usually see the vocal cords with the regular bronchoscope. That's what we used to see. But if we're using the EBUS, that's what we're going to see. If we're seeing this with the EBUS, we're not going to be able to go through the vocal cord. So we have to be able to see in the anterior aspect on the wall to be able to go through it, because the ultrasound is actually protruding past the optics. This is how we usually see the trachea, and with the EBUS view, most of the screen is covered by the tracheal wall, which is the subject of interest, as that's where we want to puncture. The needle apparatus biopsy was specially developed for this purpose. It's a single-use needle, and it has many features to help with the procedure. You have a sheet adjuster knob here. You have a sheet slider, and then you have a needle adjuster knob, a needle slider, and a stylet. The stylet is very important. It obstructs the needle while going through the wall to biopsy the lymph node, so that bronchial and tracheal tissue doesn't occlude it and fill it and contaminate the sample. After the needle is visualized inside the lymph node, the stylet is removed with the knob here, and the syringe, which is already primed with negative pressure, is attached to collect the sample. These are just few images to show you how it works. After the needle apparatus is secured, the sheet adjuster knob is released, the sheet slider is advanced. After that, we're seeing the sheet protruding, and we know that we're safe with the needle. That's not going to puncture our scope. We're happy with the position. We readjust the knob, and it's secured. Then we release the needle adjuster knob, and we're ready to do our biopsy by moving the needle slider abruptly. And we see that the needle lymph node penetrated the lymph node after this maneuver. So what are clinical applications of this technology? Primarily lymph node staging that we're talking about, but also helpful in diagnosis of lung cancer when there's no endobronchial lesions, and also for diagnosis of other mediastinal masses, such as goiter or others, and mediastinal lymphadenopathy of unclear etiology, TB, sarcoidosis, and sometimes lymphoma. So what are lymph node assessed by EBUS? There's the paratracheal, essentially the same lymph node assessed by cervical mediastinoscopy plus the Hilar and peribronchial interpulmonary. So station 2, 4, 7, 10, 11, and 12, of course, the subcarinal. Posterior subcarinal is also assessed. That's different than cervical mediastinoscopy. What are lymph nodes not assessed by EBUS? That's station 5, 6, the para and para-aortic. These needs a Chamberlain procedure or thoracotomy. Station 8 and 9, the paraesophageal and pulmonary ligament, rarely affected, but they can't be sampled. They're sampled by EUS or by thoracotomy. That's just an example of a case of a 62-year-old to demonstrate the use of EBUS. Had a 2.5 times 2 centimeter right upper lobe lesion. And then there was a 1.8 times 1.2 centimeter paratracheal in the 2R station at the level of the aortic arch. A PET scan was obtained and showed uptake in the right upper lobe, but not in the mediastinum. Are we satisfied? Can we go ahead and do the lobectomy? The guideline says no. So what are our options? The bronchoscopy, not very helpful because of a distal lesion. The lobectomy is probably not wise since they may be mediastinal spread. A transthoracic needle aspirate can help us get a diagnosis from the main lesion, but you will still need another procedure to stage the mediastinum. EUS is not very helpful here because 2R is not visualized usually by through the esophagus. So we're left with EBUS and mediastinoscopy, which can allow us to stage the patient, and if there's spread, then potentially also diagnose. They elected to go with EBUS because of it's less invasive. Here we see the lymph node visualized at 2R, and this is the superior vena cava, which we saw on the CT. next to the lymph node and recognized by the Doppler flow. That's a Doppler signal. And then a needle was advanced under real-time guidance by the ultrasound and samples obtained. We were able to diagnose this patient with adenocarcinoma and stage him with one procedure, stage 2 T1 and 2 3A stage. This is just another example to illustrate other stations. This patient had the left upper lobe lesion 1 times 2 centimeter and lymph node enlargement at station 4L. Both were positive. This is just the EBUS image that shows the aorta, the pulmonary artery, and the lymph node in between. And under ultrasound guidance, we were able to biopsy the lymph node here. So it's great. We're able to biopsy lymph nodes in the mediastinum, but is this technique reliable? What's our diagnostic accuracy? The first series reported on EBUS was in 2004 from Japan. And this study looked at EBUS for diagnosis of mediastinal and hilar lymphadenopathy in general. So they had 70 patients with enlarged mediastinal hilar lymph node size more than 1 centimeter by CT. They chose a sensitivity of 95.7 and a specificity of 100% for the diagnosis. They were able to diagnose lung cancer, multiple other metastases, thyroid cancer, esophageal cancer, lymphoma, and mesothelioma even. And they had 20 patients here with benign diseases, of whom 2 were missed malignancy, which is translated in this less than perfect sensitivity. They were able to avert thoracotomy in 6 patients and mediastinoscopy and thoracoscopy in 17. These findings were validated in another report from 2 centers in Europe and the US of 502 patients. They had a mean lymph node diameter of 1.6, and they were able to secure a diagnosis in 470 patients, leading to a sensitivity of 94% and a specificity of 100%. This is the first report looking specifically at lymph node staging in lung cancer. They had 108 patients with lung cancer, similar sensitivity, 94.6%. The negative predictive value was 90%, so they're still false negatives. And they were able to secure both a diagnosis and a stage in 20 patients with 1 procedure. They avoided 29 mediastinoscopies, 8 thoracostomies, and 4 VATs. So a lot of cost saving. That led to the EU-CE marking in 2004 and 2 years later to the FDA approval in 2006. So how does EBUS compares to CT and PET for lymph node staging? This is addressed in this report, also from Japan in 102 patients who are candidates for curative surgery. We see a sensitivity for CT 76.9%, PET scan was 80%, and EBUS TBNA superior at 92%. The specificity of CT was poor, so a lot of false positives, and 70% for PET, 100% perfect for EBUS. Now, how about the improved integrated PET-CT? In this study, EBUS was compared to this newer modality, and we show similar results. 70% sensitivity for the integrated PET-CT, 90% for EBUS, and a specificity of 60% with 100% specificity for EBUS TBNA. Interestingly, in the study, they looked at, they subcategorized the patient according to the cancer, and they found that the PET-CT underperformed mainly in patients with adenocarcinoma. So the largest number of false negative was in patients who had adeno-CA. EBUS was also evaluated in multiple subgroups of patients. This is to show the patient with PET-positive mediastinum, and it's also showed high sensitivity. Interestingly, EBUS was also shown to be quite helpful in patients with radiographically normal mediastinum. So these are 100 patients with sub-centimeter lymph node and peripheral lesions. And they underwent EBUS followed by surgical lymph node staging. Malignancy was detected in 19 patients, so sub-centimeter lymph nodes, and 19 patients had positive lymph node by EBUS. The size of the lymph node was 0.5 to 1 centimeter with a mean of 0.8. The 0.5 is the limit of helpful, where EBUS is helpful to diagnose the lymph nodes. So malignancy was missed in 2 patients, and the sensitivity was 92%. EBUS was also seen to be helpful in patients with negative PET-CT. So these are patients who had integrated PET-CT, negative 97 patient, and 9%, 8 patient had positive lymph node despite negative PET-CT. This is commensurate with the surgical literature of patients who undergo thoracotomy for presumed stage 1 and then turn out to have 3A or 3B tumor. Interestingly, again, most of the patients missed by PET-CT had adenocarcinoma, and all of them had a primary size tumor more than 1.5, most of them more than 2. So maybe give us an idea of who should really have an aggressive staging of the mediastinum if the diagnosis is known beforehand. An interesting question is mediastinal restaging for patients with lymph node involvement after neoadjuvant therapy. So these are patients 124 who received neoadjuvant chemotherapy and then underwent systematically EBUS followed by thoracotomy. And we know in these patients that mediastinoscopy is technically hard and the sensitivity is less than usual in the range of 70%. EBUS performed similar to mediastinoscopy in this study with a sensitivity of 76% to detect malignancy after neoadjuvant chemo. And regardless of whether the CT showed response by size or no response. So we started this talk by saying that the mediastinoscopy is the gold standard for staging the mediastinum. However, it seems we have a good contender here with many studies showing very high sensitivity comparable to that of mediastinoscopy. So it was very logical to perform a head-to-head comparison. In the prospective evaluation here, we had 153 patients with suspected non-small cell lung CA. They systematically underwent EBUS followed by mediastinoscopy. And if indicated, so if there's no N2 or N3 disease, they would undergo surgery and thoracotomy with lymphadenectomy. The sensitivity of EBUS and mediastinoscopy were quite similar, and as well as the negative predictive value. Complication rate was slightly higher for mediastinoscopy. And of note, of all the reports, there are very few complications reported in the literature from EBUS. How about EBUS versus EUS? We said that EBUS and EUS can sample, they have some lymph node in common, and then there's some lymph node that cannot be sampled by EBUS, cannot be sampled by EUS. So how do they compare? In this report in the JAMA in 2009, they had 138 patients with suspected lung CA who underwent blind TBNA, EBUS, and EUS systematically. Just give you a size comparison here. And then they underwent, if it was positive, then they stopped the investigation, and if it's negative, they had either mediastinoscopy or followed by imaging. The sensitivity of TBNA, blind TBNA, was 36%, quite poor. EBUS and FNA were comparable at 69% here. And the interesting finding is that if you combine them, the sensitivity would improve to 93% and the negative predictive value to 97%. So quite powerful when we combine them. That led to this randomized controlled trial where a patient underwent either surgical staging or endosonography, that's the combined EBUS and EUS, followed by mediastinoscopy if it was negative, and then every patient with a negative disease had thoracotomy. How did EBUS and EUS compare? Of course, here we have surgical staging, and here we have EBUS EUS plus surgical staging, and of course it was superior, 94% sensitivity when endosonography is integrated in the management of these patients versus 79% for mediastinoscopy. So still quite a bit of false negative here with mediastinoscopy. The negative predictive value was 86 and 93%. When the combined modality, EBUS plus EUS, was compared to mediastinoscopy, the sensitivity was not significantly different, as well as the negative predictive value. The complication rate was higher in mediastinoscopy and lower in EBUS EUS. So in summary, staging of mediastinal lymph node is crucial for management of lung CA. PET-CT are insufficiently reliable for confirming or ruling out the mediastinal spread, and guidelines recommend invasive staging for confirmation. The advantages of EBUS is the ability to diagnose, stage, and survey the airway in one procedure. It's a safe procedure, as documented in many meta-analyses, and it's highly sensitive and comparable to mediastinoscopy. The current guidelines do recommend mediastinoscopy if the EBUS sampling is negative. What are difficulties? It's a very steep learning curve and quite humbling experience for advanced bronchoscopists. At the beginning, you need a reliable cytologist, preferably rapid on-site evaluation. And the last difficulty is how to deal with false negative results. I'll stop and take questions now. Thank you.
Thank you, Hassan. So